As a clinician, Dr. Wilpers has cared for pregnant people and families facing their greatest fear, the loss of a normal pregnancy and the possibility of going home without a child. As a researcher, she explores how models of care, social determinants of health, and patients' experiences connect to care quality and healthcare outcomes. Dr. Wilpers combines these passion and skills to drive research and action to enhance healthcare and health equity for people whose pregnancies are complicated by severe fetal conditions and who may face significant challenges, including perinatal loss or preterm birth and raising a child with special healthcare needs. Dr. Wilpers completed her PhD at the Yale School of Nursing and her postdoctoral research fellowships with the Division of Maternal-Fetal Medicine and the National Clinician Scholars Program at Yale. She currently serves as the assistant professor at the University of Pennsylvania School of Nursing, where she partners with the fetal care centers from across the country to conduct policy-relevant and community-engaged research. We're so excited to have Dr. Wilpers here as our keynote speaker to start us off for the day. So I'll hand it over to Dr. Wilpers.
So good morning, everyone. I would like to express my gratitude to Dr. Bill Walker for recommending that I speak with you today following my presentation at the Spina Bifida World Congress last year. And additionally, thank you, Dr. Arman, for extending the invitation. And I am honored to be speaking today at the 45th Annual Duncan Seminar. And I'm thrilled to learn that, much like the Spina Bifida World Congress, our audience here comprises not only clinicians dedicated to caring for individuals with physical disabilities, but also advocates from the spina bifida and physical disability community and local families. So I really applaud the organizers for fostering such an inclusive environment at this conference, and I sincerely hope that your example will inspire others to do the same. So with this year's focus on spina bifida, I'll be sharing evidence today from my research on health equity related to prenatal treatment for conditions like myelomeningocele. And I know that we're not going to unmute to have this conversation, but I'm curious how many people in the audience are familiar with fetal therapy or maternal fetal surgery. Just throw a virtual hand up or a real hand up just to give us a sense of, how many people are going to be familiar with this topic. And then for those who might be new to maternal fetal surgery, I'll offer a brief overview before delving into our discussion on promoting health equity in this space. And you'll have to forgive me, but I tend to sneak in some nerdy research education into my talks because I want to make this kind of work accessible to everyone. I believe that if I can do this research, so can you. So let's jump in. So before we get into maternal fetal surgery, I would like to start by grounding our discussion in the concept of reproductive justice, which focuses on the human right to maintain bodily autonomy, to have children, to not have children, and to parent the children we have in safe and sustainable communities. A central tenet of this movement is grounded in the hypothesis that if we center the most marginalized people, care improves for everyone. The reproductive justice framework and movement was founded by activist women of color like Dr. Loretta Ross through Sister Song, the Women of Color Reproductive Justice Network. So if you're not familiar with this organization, I highly recommend becoming a member. So with this framework as my guide, I explore how the intersection of care models, patient experiences, and social determinants of health intersect with healthcare quality and health outcomes, as Dr. Arman said. And this quote, taken from a piece shared anonymously at a local community event called Centering Black Maternal Health Through Poetry, I think really powerfully reflects how the individuals under our care, for those of us who are clinicians, perceive the interplay of these factors. Now, I know you have your own fantastic fetal care and treatment center here at Seattle Children's, but for those in the audience who may be less familiar with this approach to prenatal care, maternal fetal surgery is a relatively new and evolving field in maternal fetal medicine that involves surgical intervention during pregnancy to address fetal conditions like spina bifida. Since its inception in the 1980s, prenatal surgery has become increasingly common, with clinical research such as the management of myelomeningocele study or MOMS trial playing a pivotal role in demonstrating its benefits and shaping clinical practice. Now, I probably don't need to tell this audience, but a quick overview, the MOMS trial and then subsequent follow-up studies showed that prenatal repair compared to postnatal repair has benefits, including reduced rates of hindbrain herniation and shunt-dependent hydrocephalus, as well as increased rates of independent ambulation, as demonstrated on this slide by those adorable little ones on the right. And a resounding message from people who choose to undergo maternal-fetal surgery is that they want to do everything they can to address the fetal condition. As one participant in a qualitative study explained, if it doesn't work, if he needs a shunt and he never walks, well, at least we can say we did everything we could at the time that was available. However, maternal-fetal surgery poses risks for both the pregnant person and fetus. Even less invasive fetal interventions come with risks, such as inducing preterm labor. And while survival rates for fetuses have increased significantly, there is always a risk of pregnancy loss or fetal death when performing an intrauterine procedure. Even if the surgery goes as planned, it's important to keep in mind that most procedures do not cure the fetal condition, but rather mitigate the condition's negative effects. Fetal surgery poses risks to the pregnant person as well, not only during the procedure itself, but also throughout the remainder of the pregnancy, and potentially during any future pregnancies, depending on the procedure that they went through. Risks for the pregnant person include infection, bleeding, blood clots, placental abruption, and uterine damage. In a recent systematic review of the literature, they found that an overall complication rate of approximately 21% for open procedures and 6% for minimally invasive procedures. But when you think about these numbers, it is important to note that historically, many studies of maternal-fetal surgery have failed to document maternal complications. So as you can see, the choice of whether to undergo maternal-fetal surgery for a condition like spina bifida is multifaceted and difficult for any pregnant person and family to make. So I'll share with you today 3 studies that focus on health equity and perinatal care by examining maternal-fetal surgery for conditions like spina bifida and others that can lead to physical disabilities. And a quick note about my language use, you'll hear me switch between fetus, baby, and child. I use fetus when I'm speaking technically and medically, and baby or child when I'm speaking from the perspectives of patients or study participants who use that language to speak about their own pregnancies. And this is an approach that I've carried over from my clinical practice, and the goal is to be both accurate while being respectful of differing views. Now, to study health disparities, we need solid evidence that helps us understand diversity and representation, right? So in my first health equity study, we set out to see what evidence we had in maternal-fetal surgery as a field to tackle this question. So when we think about studies like the MOMS trial that so powerfully shape clinical practice for conditions like spina bifida, there's an important question that we need to ask about studies like these. Who is being included in the study sample? Sociodemographic information about study participants, such as their age, race, ethnicity, and socioeconomic status, allow clinicians and other stakeholders to assess external validity, in other words, determine the applicability of a study's findings to their own population, ensure that the disease population is being represented, in other words, are we studying the people who are most commonly burdened by this disease, and thorough and consistent reporting of participant sociodemographic characteristics in clinical research is necessary if we want to identify and understand potential health disparities. So we conducted a systematic review of all randomized control trials and cohort studies examining the efficacy of maternal-fetal surgery. And we looked at studies, anything that was published after 1990, and we also looked at how often these studies reported the 9 sociodemographic variables listed here. We also looked closely at whether studies listed sociodemographic factors as a part of their inclusion or exclusion criteria. So for example, were there some studies that perhaps included English speakers only? Finally, we looked at the participation to prevalence ratio, or PPR, and this is a measure to describe the representation of specific groups in research with respect to their proportion in the disease population. We calculate PPR by dividing the percentage of racial and ethnic groups among study participants by the percentage of racial and ethnic groups in the disease population. So for example, the percent of Hispanic women included in fetal surgery studies of myelomeningocele divided by the percent of children born with myelomeningocele in the United States who are Hispanic. And a PPR that's greater than 1.2 indicates overrepresentation. Between 0.8 and 1.2 suggests adequate representation, and less than 0.8 indicates underrepresentation. Of the included 112 studies that we found, 10 were randomized control trials and 102 were cohort studies with comparison groups. As you can see in the bar graph on the left, most manuscripts were published in the last 10 years, and the map on the right shows you the countries where studies were conducted, with the majority taking place in the United States and in Europe. To give you a little bit more background on our sample, the number of sites involved in the studies ranged from 1 to 21, with most studies being conducted at single sites. Sample sizes ranged from 5 to over 600, with a median of 58 participants. And this pie chart shows that while twin-twin transfusion syndrome was the most common disease group, it was followed by myelomeningocele and congenital diaphragmatic hernia. So in terms of our primary outcomes of interest, as you can see in the bar graph, sociodemographic participant characteristics were rarely reported. Out of our total 112 manuscripts, the most frequently reported sociodemographic variables were maternal age and childbearing history. Race and ethnicity were only reported in 12% of studies, and less than 10% of studies reported any other sociodemographic variables. Of note, you can see in the pie chart that of the 47 studies conducted solely within the US, only 12 or 26% reported race or ethnicity. So if you were thinking, well, I wonder if it's because this low reporting is because the international studies don't use perhaps some of the same categories and characteristics that we would use in the United States, we had that thought too. So then we looked just at the United States studies and we still saw this lack of reporting and lack of representation. And this is striking given that the majority of the US studies were published in the last 10 years. And over the last 10 years, there have been more calls for sociodemographic reporting from journals and funding agencies. And even though sociodemographic variables were rarely reported, they were cited as exclusion criteria in 13% of studies. 6 studies reported using the management of myelomeningocele study criteria, but did not specify what that included or how the psychosocial contraindications were assessed. And I've listed those criteria for your information here, which include the pregnant person having no support person, inadequate support at home for pregnancy, inadequate understanding of risks and benefits, and inability to comply with medical restrictions for follow-up. These criteria were, of course, designed with maternal and fetal safety in mind, but you can see how a possible unintended impact of structural discrimination and implicit bias can play a role in determining participant eligibility. And we'll come back to this a little bit later in the talk. So to calculate the participation to prevalence ratios, we use the most recent report from the National Vital Statistics Birth Database for the twins, and then the most recent report from the National Birth Defects Prevention Network for myelomeningocele prevalence. And unfortunately, the remaining conditions did not have sufficient population or study sample race and ethnicity data for us to be able to calculate PPR. But luckily today, we're talking about spina bifida. So in this figure, the PPR range is on the x-axis, with the green bar showing that range for adequate representation. And census tract racial and ethnic categories are on the y-axis. So on the bottom, you can see that white persons were consistently overrepresented relative to their prevalence in the US disease populations. Asian, Black or African American, and Hispanic or Latino persons were consistently underrepresented, and American Indian or Alaskan Native and Native Hawaiian or other Pacific Islander persons were not included at all. As perhaps the most striking example of population and sample discordance, the box on the right shows that Hispanic persons account for 40% of the myelomeningocele population in the United States, but only 10% of the participants in maternal-fetal surgery studies of myelomeningocele. So based on our findings, our team concluded that, unfortunately, sociodemographic reporting quality in maternal-fetal surgery studies is poor, which limits external validity and inhibits examination of potential health disparities. In addition, participants enrolled in studies in the United States do not adequately represent the racial and ethnic diversity of the population across disease groups, even when specific racial or ethnic groups are most burdened by the disease. And these findings closely reflect the largely homogeneous samples reported by researchers like Ali Harbert from the University of North Carolina, Chapel Hill, and Dr. Foy from Children's Wisconsin, who examined their own sites' prenatal MMC repair populations and also found concerning patterns like prenatal repair being associated with commercial insurance. And around the same time, a population-based study was conducted by Dr. Best, also from Children's Wisconsin, and her findings reflected the patterns that we see here, but also found that prenatal repair was associated with higher income zip codes. So you see the picture that all of these data are painting. So following this publication, we advocated with journals for sociodemographic reporting standards and diversity enrollment targets to be established for the journals that most commonly publish maternal fetal surgery studies in order to improve generalizability and representation. As an example here, you can see the reporting requirements for JAMA network journals, which require that specific demographic information be reported, and if not, that at least the reason for this should be stated. Inclusion of diverse participants will, of course, lead to more robust and comprehensive data that expands our understanding of potential sociodemographic differences in access to care and decision-making, treatment responses, and outcomes. So now that you have a sense of the approach that we started with this systematic review to examine health disparities in maternal fetal surgery, let's turn to the exploration of this topic through qualitative research. And for those of you who are less familiar with qualitative research, this is going to be one of my little mini research education moments. These studies use words rather than numbers as their data. So this could be anything from interviews, like what you'll hear that we did with this study, to focus groups, to written texts that you're analyzing. And these studies are often exploratory in nature and seek to generate novel insights using inductive rather than deductive approaches. So in other words, starting with observations and developing hypotheses rather than starting with hypotheses and then testing them with observations. Because we can't measure what we can't understand, right? And qualitative research also focuses on complex phenomena that are difficult to measure quantitatively, such as values, beliefs, and motivations that underlie individuals' behaviors, because not everything that counts can be counted. And as you'll see in the coming slides, qualitative methods are often used to develop subsequent quantitative investigations, such as person-centered measures in healthcare, and that's just a sneak peek as to what's coming. So let me get down off of my qualitative research soapbox and talk about how we use this approach to triangulate our research on potential health disparities in maternal fetal surgery. I incorporated this examination into a qualitative study which focused on how clinicians across the country communicate with pregnant people about maternal fetal surgery. So in this study, we interviewed physicians, nurses, psychosocial professionals, and genetic counselors affiliated with maternal fetal surgery practices about how they learned their patients' values, beliefs, and sociodemographic contexts, and how that knowledge may or may not influence their discussions about maternal fetal surgery. As part of our health equity-related questions, we asked about their experience with historically marginalized groups and cases where structural discrimination may have influenced a patient's care. Our focus was captured by a recurring statement that was reported by nearly all of our participants, and they reassured patients along the process of counseling by saying, "You will be supported in any choice that you make." And this could encompass the range of potential care pathways for conditions that are eligible for maternal fetal surgery, which could span prenatal and postnatal interventions, expectant management, which is sort of the watchful waiting approach during pregnancy, perinatal palliative care, or termination of pregnancy.
I think there's 20% off on an outline.
The ubiquity of this statement showed how participants cared deeply and were committed to helping patients make informed, empowered, and autonomous decisions. However, many participants also felt that some eligibility criteria for maternal fetal surgery, although designed for safety, can also compromise pregnant people's agency and disproportionately affect socioeconomically disadvantaged individuals. So as you might remember, 13% of the maternal fetal surgery studies in our systematic review reported excluding people for psychosocial reasons, including a person who's perceived to have no support person, inadequate support at home for pregnancy, an inadequate understanding of the risks and benefits of maternal fetal surgery, or an inability to comply with medical restrictions for follow-up, such as a significant decrease in maternal activity. And I bring this list up again because I think that this is a helpful way to think about it now within the context of patients' lives. So especially this last bullet point about how the restrictions for maternal activity. Now, that's the kind of depends on the procedure that somebody has, but that you can imagine, not everyone can uproot their lives and afford to take time off of work or stay close to the hospital for those hospitals that have that requirement or certain procedures that require people to stay close. And then think about when other people have kids at home, right? So what if they can't get full-time childcare to make up for the loss of their ability to pick up their kids, like physically and like from school, to run after them? This is something that really significantly can affect the pregnant person's ability to go through their activities of daily living. So as one MFM said,
peanut butter and jellies or bring bread in.
Oh, I think we need somebody to mute themselves.
Please check your mute, everyone.
Okay. So as one MFM said, to make a true autonomous decision, pregnant people need a better healthcare system in the United States and better social support.
Yeah, I don't think like
echoed
I ain't gonna bring
by-
one because I haven't fully. I one got covered in paint and I haven't fully cleaned it off.
Andrew Woolley is not muted.
Just pretty much picnic. We can eat out when we want to. Andrew, Mindy, can we
I was
mute?
just thinking if we did like one evening in that like divey bar.
One sec.
Oh, there
I
we
got it. I got it.
All right. Mindy to the rescue. Thank you. All right. So as one MFM said, to make a true autonomous decision, pregnant people need a better healthcare system in the United States and better social support. And this was echoed by other participants who described challenges of navigating the inequitable influence of social determinants of health with their patients. So in contrast, other clinicians had concerns about taking social determinants of health into account in their communication with patients. So as one participant said, I have very mixed feelings about it because I see my role more as being the person to convey the facts around the diagnosis and the options. I feel like if I start to dive too much into social issues, or maybe I'm wrong here, I don't know, but I feel like they might misinterpret that as me trying to impose my views or my thoughts. But I guess I just don't know how to effectively talk about their psychosocial context or if I should even do that. But some of these issues were unavoidable, like language barriers between clinicians and patients. As this participant went on to say, I know enough Spanish to know that half of the time the interpreters are not saying anything close to what I'm saying. But the challenge is also the ability to communicate empathy. I find that darn near impossible with an interpreter. And then it becomes even more compounded if they are of low medical literacy. Do they really know and understand the information that I wanted to communicate? I think the answer is probably no, no matter how much time I spend. So I think that these two quotes, when you put them next to each other, poignantly illustrate the tension that can exist between our commitment to support the autonomy of our patients around maternal-fetal surgery decision-making and the reality of the inequitable healthcare system and turmoil surrounding reproductive rights and justice in the United States. As a result of this tension, the widespread message that patients will be supported in any choice they make from clinicians may ring hollow and breed resentment and distrust when that doesn't pan out, especially for pregnant people in historically marginalized groups and socioeconomically disadvantaged individuals. Our findings are guiding a follow-up study in partnership with the Rutgers School of Social Work, in which we interview former patients who received care at various sites nationwide about their experience with being counseled about maternal-fetal surgery. Our goal is to enhance our understanding of communication practices and their impact on patients, and to contribute to evidence-based guidance for clinicians. So how do we turn this qualitative data and this early systematic review into something where we can measure so that we can examine health equity across diverse settings and populations and really dig into the incidence and potential drivers of health disparities? Well, my approach was to integrate these equity-focused concepts and methods of my previous work into the development and validation of a person-centered care scale for fetal care centers, which is where most maternal-fetal surgeries take place. Now, just a quick note about fetal care centers and our justification for choosing this setting. Prior to the development of fetal care centers like the one here at Seattle Children's, the traditional model of fetal diagnosis and care was very fragmented. Patients and families navigated a series of specialists in different locations, such as maternity care, diagnostic imaging, genetics, pediatrics, neonatology, all while experiencing overwhelming stress and confusion. As one participant in a qualitative study explained, I saw the pediatric consultant just once, but that was after the baby was born. No doctor knew what the other had told me. There was a real lack of communication. The fetal care center model, which began in places like UCSF and CHOP, brings all of these specialists and services together under one roof to provide care by multidisciplinary teams and to deliver coordinated, person-centered perinatal care and offer fetal and/or neonatal interventions. A nurse guides the pregnant person, figuratively and quite often literally, throughout the pregnancy. And this nursing role has been described as the glue of fetal care centers, so shout out to the fetal care center nurses in the audience. One of the primary motivators and marketing strategies for these centers is the goal of delivering person-centered care, which ties closely to the idea of providing equitable care to all. So the research I'm presenting today aims to explore the characteristics of person-centered care in fetal care centers to establish measures for these services and investigate their connections to health equity and health outcomes. So let's take a closer look at person-centered care. Now, person-centered care is respectful of and responsive to an individual's preferences, needs, and values. So you can see how this ties into health equity, right? We all have different preferences, needs, and values that are influenced by social determinants of health. So you can't really have health equity without person-centered care, and inequity in health and in the healthcare system is a huge barrier to providing truly person-centered care to all. But of course, person-centered care is what we all strive for as clinicians. And sometimes you can really feel when you've provided that to a patient and their family, even when their health outcomes might not have been optimal. And that's because person-centered care helps patients to have a positive care experience, which can help them participate in their care, set realistic expectations, and cope with the loss of a normal pregnancy. And while existing instruments can measure some aspects of this concept in fetal care centers, such as the person-centered maternity care scale or the person-centered prenatal care scale, recent qualitative evidence, some of which we've talked about today, has highlighted the unique characteristics of person-centered care in fetal care centers and the distinct challenges that we face in our person-centered practice. So the objective of this study was to develop and validate an instrument to measure quality indicators of person-centered care in fetal care centers across the country. Now, developing an instrument is a multi-step and multi-method process, which some people in the audience may know all too well. So we'll walk through each step and aim of our study and get ready to wrap up our mini research education series with a bang. Our first aim was to generate initial items for the instrument, and in scale development, items mean questions. So if I ever say items, think of that as a question on a survey that would be asked to the patients. We defined a fetal care center as a multidisciplinary practice specialized in providing coordinated fetal diagnosis and consultations for pregnant people in a tertiary care setting. To determine the content domain of person-centered care in fetal care centers, we drew from national and international guidelines. We also examined existing perinatal person-centered care scales, relevant health policy, FCC guidelines, and qualitative evidence from FCC patients about their own care experiences. And this qualitative evidence represented the voices of over 230 fetal care center patients. These data were reviewed and organized by our interprofessional and multidisciplinary research team, which included fetal care center leaders from across the United States and a co-investigator with lived experience who co-founded and leads a nonprofit charity that provides medical information and unconditional support to families dealing with fetal conditions. So shout out to Fetal Health Foundation. Now, after an iterative process of item generation and discussion, we concluded this process with 51 initial items designed by the research team. And next, we used the Delphi method to establish face validity. And face validity is essentially the assessment of whether an instrument appears to measure what it's intended to measure based on initial observations by stakeholders. And the Delphi method involves reaching this consensus through multiple rounds of structured feedback from a panel of diverse experts. So to accomplish a well-rounded opinion, panelists in this study who were helping us to determine exactly which items should be included in this instrument were lived experience experts, in other words, people who had experience as FCC patients with a variety of care and outcomes experienced, and professional experts representing the diverse composition of an FCC team, including advanced practice nurses, MFMs, pediatric surgeons, a pediatric cardiologist, a neonatologist, a nurse care coordinator, a nurse manager, and a social worker. These teams are big. After the first round, in which panelists provided qualitative feedback on our items, so we got to hear their thoughts about each question, then the survey was revised based on their feedback, and we returned it to panelists for their vote on whether each survey item was relevant and clear. So we went from qualitative data to quantitative data. The Delphi study concluded with 48 final items or questions for the Person-Centered Care in Fetal Care Centers survey. We concluded that the instrument should be administered at the conclusion of FCC care, so either that being discharge from the hospital or transfer of care back to a local prenatal provider after a fetal intervention. So while of course we can't talk about all 48 items today, I've pulled out the items that centered around health equity. So you can see we asked if the first question there, number 12, I felt like I had to fight for my needs and wishes. This is actually a question that really comes directly from a person-centered care scale that was adapted and revalidated to make sure that it captured the experiences of people of color. And this was one of the most significant differences between people of color and those with a white background, where people of color really said they had to fight for their needs and wishes, and that was not something represented in the initial validation of the instrument because it didn't have enough representation of people of color to discern that. So we included that question. We also asked if people felt discriminated against during their care and listed a few reasons, since I think sometimes this is not something people always think about, all the ways in which this can happen, unfortunately. We asked if people faced financial challenges related to their care. We asked if they were told about all of the possible options for their pregnancy and told about them in a compassionate way, because options might not feel real if they're not presented all in the same way with detailed information and support. And then the FCC team helped me make decisions that were best for me and my family. So again, thinking about how the medical information is being grounded in decisions that have to have a lot more in the context for the families than just the medical aspects of things. Oh, and just at the bottom, just to make things a little bit easier to understand. So for each of these items, we asked people to rank how much they agreed with it on a Likert scale. So all of the scoring is based off of 1 through 4 scores, from strongly disagree to strongly agree. And then we did have an option for does not apply, since fetal care experiences can be very diverse. So you can see how this process led us from 51 total items just developed by our research team brainstorming and collecting data to a polished series of items that went through rigorous feedback from multiple stakeholder perspectives, including better representation of the target audience. And this also allowed us to organize the items into 6 domains based on referral and access, physical and emotional environment, communication, support, decision-making, and care continuity. So essentially, we hypothesized that these 6 domains are what made up the concept of person-centered care in fetal care centers. So now that we knew our instrument made sense to representatives from the fetal care center population and our target population of patients, now we needed to pilot the survey in order to conduct psychometric analysis. In other words, we needed to statistically test the consistency and accuracy of the instrument to ensure that it effectively measured what we intended to measure. So you can see our pilot study flyer here on the left. We recruited former patients from fetal care centers around the country and online support communities relevant to fetal diagnosis and treatment so that we could analyze their pilot data and conduct exploratory factor analysis. So you know when you're doing a puzzle and you sort the pieces into groups based on similar colors to help you put that bigger picture together? Well, in exploratory factor analysis, these groups of puzzle pieces are called factors, and they represent groups of questions that may make up a domain. So you remember the domains that we thought would make up person-centered care. This statistical approach helps us to use real data rather than our hypotheses to show us where these groups of questions made sense to hang together. And this helps researchers understand how individual items are related to each other and whether you might have pieces that don't actually fit in that puzzle or something's missing from the big picture. Because as researchers, we can only hypothesize which questions are important and how they relate to each other, but we need evidence from the target population to be sure. So this basically is a way to check what questions in a survey are most important, how to best organize them into groups or factors, essentially checking our own work where we separated the questions out into those 6 domains. So through this process, we were able to enroll a total of 258 people. And to pull out a couple of key variables from our sample, our participants were primarily white, married, held private insurance, and received care in the Midwest. Types of care received were different combinations of consultations, fetal intervention, neonatal intervention, palliative care, and termination of pregnancy. And we will come back to discussing this sample at the end. So our 3 aims resulted in the PCC-FCC scale, a 28-item, 2-factor solution, so 2 groups of questions that hung together because they measured similar and important domains within the concept of person-centered care. So factor 1, or the 19 items that group together under one factor, we interpreted as the concept of feeling cared for, which focused on the respectful and compassionate caregiving tasks and included the technical competence and effective communication of the healthcare team. So some example items include the FCC team listened to me, clinical care was done with compassion, and the environment supported my physical needs. And the loading numbers here on the right represent the strength of the item's relationship to this group of questions on a scale of 0 to 1. So as you can see, the items with the higher numbers are the ones that were really driving a lot of the findings that we were seeing. We interpreted factor 2 as the concept of feeling cared about. So one group of questions seemed to center around how they felt cared for, and the other group of questions seemed to center around how they felt cared about, which focused on meeting the health-related quality of life needs of the patient. And these items we felt were more specific to fetal care centers compared to some of the items in factor 1. So some examples include providing resources to help with emotional health, helping the patient learn how to talk with friends and family about their pregnancy, and asking about expectations and hopes throughout the care experience. Because as we know, these complex pregnancies can change over time. So one of the things we saw in the qualitative literature were families feeling that as their condition changed and the prognosis changed, so too, of course, did their hopes and wishes. But if that was not documented consistently, that caused problems with the ability to provide person-centered care, of course. So you can see where, we don't have the health equity items as much a part of these examples, just because these were some of the ones that loaded the highest. But they were kept in the survey by the statistical analysis. And what got thrown out were 20 items, which mainly focused on referral experiences and concepts that overlapped with other items. So these were items that really didn't seem to drive, the scoring very much, or they were super consistent across sites. So you can see really how this process of statistical analysis with the pilot findings is so important, because we, of course, thought all the items were important, but these 20 were thrown out by actual patients and statistics. And we had a completely different idea for the domains that determined how we organized these items initially. You saw how we had those 6 domains at the very beginning, but here, patients and numbers told us that there are really only 2 domains in this person-centered care: feeling cared for and feeling cared about. Now, that's not to say that the other items that were excluded aren't important. They may just be aspects of care that are more consistent, or they could be part of another concept that might just need its own instrument. So I shared these last numbers just in case there are any fellow scale development nerds in the audience, but in summary, the data supported content, construct, and concurrent validity. Concurrent validity means that we also had our pilot participants take a well-established person-centered survey so that we could compare and say, are our person-centered findings similar to this much more validated, well-established instruments findings? And we found that they were, so that was positive. So you've seen a few sample items from the scale, and because we are currently in the process of copywriting it to ensure protection before making the entire scale publicly available, but our plan is to allow fetal care centers across the country to access it. So I'll just give you a further sneak peek. Given today's topic, the instrument covers issues of access to care, consistent communication and value-based language across multidisciplinary teams, maternal agency and options counseling, financial hardships, and discrimination. So in summary, we found that the PCC-FCC scale is a reliable and valid measure of person-centered care in U.S. fetal care centers, and it can be used to enhance services and begin connecting person-centered care to maternal-child health outcomes. So where do we go from here? Well, I recently applied for an NIH grant to support the rollout of the PCC-FCC scale at 19 sites across the country, where we propose to examine correlations between PCC-FCC scores and maternal mental health outcomes, evaluating potential associations or disparities across sociodemographic factors. And this aims to be one of the largest and most expansive investigations into maternal mental health among the fetal anomaly population. So fingers crossed for this one. And in addition, did anyone notice the irony earlier when I showed you that sample from the pilot study that was seriously lacking in diversity and representation? Despite our best efforts, this was a major limitation of our pilot study and something that we are aiming to immediately address in follow-up research. We had been banging our heads against the wall, continuing to enroll, trying to make adjustments within the study framework that we set up, and we just were not getting the diversity that we had hoped to get. Now, this observation may accurately portray a problem with diversity and representation in the FCC patient population from which we were sampling, but we can't rest on that assumption, and we have to adjust our approach to better capture all people's experiences. So this involves the ongoing translation of the PCC-FCC into additional languages, employing alternative data collection methods that don't rely on participants having internet access, among other approaches to better recruit a diverse and representative sample. I'm also thrilled to be collaborating with Judy Thibodeau and the Spina Bifida Association on a study of multiple national perinatal databases to assess association of sociodemographic variables with perinatal care for myelomeningocele. So I think as many of you would be familiar, up to 30% of MMC cases are still undiagnosed until after birth. And that is something that we don't have a lot of data on how and why that happens. So one of the things that we are looking at is what factors are associated with prenatal versus postnatal identification of the condition, as well as prenatal and postnatal treatment. And I'm quickly learning just how long these population studies can take, but we look forward to helping answer the call for robust population-based evidence and joining the pioneering researchers that I mentioned earlier. And if this is if this is an area for you in your research, I welcome you to share more about your findings as part of our discussion. And among other projects, I am also particularly excited about sorry, I had was behind on one bullet there, but among other projects, I'm also very excited about the ongoing development of a longitudinal mixed methods study that will examine the experiences of a diverse population of people in the US whose pregnancies are complicated by a severe fetal condition, in order to, again, determine the impact of social determinants of health on prenatal versus postnatal diagnosis, the options that were presented to pregnant people at the time of diagnosis, and patients' perceptions of care quality and the potential barriers and facilitators to accessing their desired and risk-appropriate care. So to our knowledge, this will be the first national longitudinal study to examine potential health disparities across severe fetal conditions. And that is what I have for you today. So I want to again thank Drs. Walker and Arman, as well as Mindy and the entire Duncan Seminar Planning Committee for the support to speak today. And I really look forward to hearing your thoughts and questions. Thank you.
Thank you so much, Dr. Wilpers. Thank you so much for all the amazing work that you do, all the research that you do in equity and access in healthcare and representation in research studies. That's amazing. And what really stood out to me was the racial disparities in access to fetal surgery, particularly for our Hispanic and Latinx populations.
Mm-hmm.
Yeah, and I think we have time for a few questions.
Great. I'll leave the slides up in case people want me to go to a specific slide, but I can take them down if that doesn't seem to be the case.
If anyone wants to just drop a few questions in the chat, we can go from there.
We have one question in the chat from Dr. Dan Doherty. How have recent shifts in legal status of women's reproductive care across different states impacted your research?
Such an important question for this moment in our country's history. Yeah, that is an overwhelming question and experience. I would say that it has been extremely challenging for everyone in this field to sort of figure out how to move forward in a way that doesn't make the negative outcomes of these legal decisions even worse. So in terms of it affecting my research, it really has just become a bigger part of the questions that we ask. And then, in terms of it affecting this field, there are procedures that are at risk, such as laser ablation for twin-twin transfusion syndrome, and others that might risk being misunderstood as termination procedures that would be outlawed. So I think that is another big piece that we're going to be looking at, is how are the bans on abortion care affecting our ability to actually help people and save pregnancies where without the intervention that could be, again, misunderstood as something that is illegal in the state, where the goal of that treatment is actually to save lives. And that's something that, again, we've just, it's just been a huge barrier in us continuing to move forward with both this clinical work and this research. I appreciate your question, and please follow up if I did not answer everything you were thinking of.
From Dr. Doherty, were you able to separate the impacts of language from race and ethnicity?
So for, the systematic review, language wasn't reported in any of the studies. So that one, we don't have any evidence there. Our qualitative, we aren't really looking at the influences so much because it's this, smaller exploratory study, but you saw some of the quotes that had to do with how language can drive some of the disparities that we're seeing, most likely does, because if people are not understanding their options, then they might be considered as not eligible, right? Because they might be considered as not having a sufficient understanding of risks and benefits, or they might be eligible, but now they've gone through a procedure where maybe they didn't really understand really important parts. One of the most common things we see are women not understanding or pregnant people not understanding just how significant of a surgery for themselves these issues can be. So I think that is some of what we're starting to see in these early stages. But the studies that have looked, larger quantitative studies that have looked at this question of sociodemographics and have looked at language specifically, again, it's so rare that language piece is reported. So oftentimes it gets sort of as a proxy, people will look at, at race and ethnicity, but they really, I can only think of maybe one study that looked at, and I can't come up with it off the top of my head, but where they actually looked at the difference of primary language spoken and how that affected the timing of diagnosis for a fetal condition. and found that I believe that the difference of if English was not their primary language, that there was a delay in diagnosis by a few weeks at least. So if you think about it from that upstream perspective, if it's affecting, diagnosis even, then most likely, the effects are only going to be compounded as time goes on because there are so many factors that have to do with the timeliness of this work. So I wish I could say more about the language piece, but that's still really early research as far as I know.
Thank you. There's a couple other questions in the chat. There's one from Stephanie L. She says, amazing topic. I studied Spanish as my first major, then added nursing as my second. In my time in nursing, I've noticed multiple literacy and cultural barriers that may impact diverse participants' ability to participate in research. Question, has there been any thought about using cultural navigators in FCC care?
I love that question. Thank you for sharing your background. So I hope so. I know that there are certain groups, I think it's the Midwest Fetal Care Center that's looking at patient navigators, but from the community, right? So not somebody who's necessarily hired and works for the hospital as helping to navigate patients throughout, but actually specifically looking for people in the community who have a sense of certain groups and certain cultures so that they can really help represent those families and be a partner with them as they go through their care. That is the only site that I happen to know of who is using a sort of a similar model to what you're talking about in terms of culture. But I think that that's, a long time ago, we called for the need for a patient advocate who is not necessarily one of the providers, is not necessarily the patient's family, to be involved in maternal fetal surgery decision-making, but that never seemed to happen, right? So I think that this is another area where there's a lot of room for exploration, and I welcome, one of the roles that I hold is as I'm the research chair for the Fetal Therapy Nurse Network. And what we love is for people to send us their questions. It can be, not necessarily something that feels like a research question to you, but it's something that came from your, clinical experience. Share those questions with us. Share what's bothering you in your clinical practice. And then what we do is try to help people see if there's a accessible research question that they can follow to be able to answer some things like this. So that feels like the exact kind of content and exact kind of topic that we would love to think about. How could we find out who's using this approach and how it's working and how we can maybe benefit from that kind of a service more broadly.
Another question from the chat from Diego. What type of outreach efforts were made to recruit diverse research participants in the community?
So I would imagine that this was for the pilot study. And what we did for that study, we really kind of were early in figuring out how we were going to go about trying to recruit a diverse sample. So our methods really were not that well informed, and that might certainly be why at the time we did not get a very diverse sample. Most of what we talked about was with the recruiting sites to try to have a sample that was representative of their patient population. The other actions that we need to take are things that we're going to be going through, having more people on the research team who speak multiple languages. We're going to go through, cultural training related to research recruitment and things like that to really improve and not just say, do as we say, not as we do, because we really did not come through for the pilot study with a diverse sample. So yeah, I'm very pleased. Put in the chat if you have recommendations beyond what I listed. I'm very, very open and welcoming of that. So.
There's a question from Emily Myers. How does your work on patient-centered care align with work done in neonatal intensive care units?
Align with work done in neonatal intensive care units. I think I understand where they're coming from. So I work closely with Dr. Scott Lorch, who is an epidemiologist and neonatologist and runs the health services lab for the NICU at CHOP. And it's such a great partnership because, I'm coming from this much more sort of maternal side. My training is as a women's health nurse practitioner. And I think of the sort of fetal time a lot. And sometimes, once the babies are born, that's I'm a little bit, from a clinical perspective and research, sometimes I'm a little bit less involved. So I'm partnering with the NICU, and there's so much robust research coming out of NICU studies of things like disparities and, person-centered care, that it's sort of right now this silo, right? There's what gets done in the NICU, and then there's sort of the fetal world. And I think I'm hoping that there's more and more partnerships where people are saying there are a lot of really good opportunities to look at things starting in the fetal time and then moving forward to give us this more longitudinal perspective, but to really benefit from the fact that NICU folks have been doing this longer than the fetal folks have. So I think that partnership can really be mutually beneficial, and I hope that there's more of that moving forward.